Good afternoon. On behalf of the Department of Pulmonary Critical Care and Sleep Medicine, I welcome you all to this clinical combined round today afternoon. Our The case that we have chosen pertains to tuberculosis, which is still the commonest infection of our country, as we all know. All of us treat tuberculosis in various forms in the acute stage, but here we are going to present something which comes later. Over a period of time, in the last couple of years, we have been seeing more and more cases which are kind of complications of tuberculosis and not the acute stage tuberculosis. And the burden of chronic sequelae of tuberculosis in various forms is gradually increasing. The burden in our OPD as well as in the inpatient, we see a lot of like post-tubercular bronchiectasis, for example, and even in the inpatient now the burden and the proportion of tubercular sequelae related cases is increasing. Probably other departments may be having the same experience. So here we are showing one case which was a problematic management case from that point of view, and we'll try and show you how we managed to deal with that particular case. And for that, I'll call upon our DM fellow, Dr. Vidushi, to present the case, and that will be followed by a literature review by Dr. Rahul Tyagi.
Thank you, sir. I would now like to begin with the case presentation. We have a 26-year-old lady, never smoker, married, homemaker, who presented with complaints of breathlessness for 10 months, cough for 10 months, and chest pain for 7 months. Her symptoms developed 10 months back with acute onset, gradually progressive breathlessness, which was associated with wheeze, but no history of orthopnea or pedal edema. The symptoms were worse during winters. At the time of presentation, she had grade 2 MMRC. She also had cough for last 10 months, which was episodic and paroxysmal, sometimes productive, with minimal mucoid expectoration. There was no hemoptysis, no nocturnal awakening. She had chest pain for 7 months, initially episodic, severe right-sided chest pain during the episodes of breathlessness. For the last 2 months, this has been persistent, dull aching. The pain was non-radiating, not increasing with exertion, not associated with palpitations. Patient has had no history of fever, hemoptysis, anorexia, or weight loss during this period. She also does not have any symptoms of joint pain, skin rash, epistaxis, or oral ulcers. Her past history is significant for TB 1.5 years back when she was diagnosed with right-sided pleural effusion and took ATT for 6 months. She has no history of diabetes, hypertension, or coronary artery disease. She had one live issue 1 year back. Otherwise, personal and obstetric history are unremarkable. For these complaints, she was evaluated first in February 2021 in a private hospital. A PFT was done, which showed a ratio of 61.1. And there was a mixed obstructive plus restrictive defect. She was advised nebulization but had minimal symptomatic relief. So she was admitted. She got a CT chest done at that time, which had been reported as a right lower lobe consolidation. We do not have those images at present. She also underwent a bronchoscopy, which showed extensive right main bronchial stenosis, and the scope could not be negotiated. A balloon dilatation was attempted. The patient was further treated with inhalers, but due to persistent symptoms, she was referred to AIIMS now in July 2021. When she came to us, she had persistent dyspnea and chest heaviness. On presentation, patient was conscious, was not in respiratory distress. The general physical examination was within normal limits. Her respiratory system examination revealed features of right-sided lung collapse. Her other systemic examination was within normal limits. She had come to us with recent X-rays and CT scan, which will now be discussed by our radiology colleague, Dr. Malvika.
Thank you, Dr. Vidushi. I'll be presenting the imaging of this patient. We have 2 serial radiographs of this patient. The first is dated 4th of June 21, which shows that we have a triangular opacity here in the right paravertebral location and an opacity here in the right lower zone, which is obscuring the right hemidiaphragm. We also see that the right hilum is pulled down and there is rib crowding here on the right side. These findings suggest that there is a subsegmental right lower lobe collapse. Following this, we have a radiograph approximately 1 month later, done in July 21. in which we see that now there is progression. There is a whiteout right hemithorax with ipsilateral tracheomediastinal shift and rib crowding on the right side, suggesting now that now there is a complete right lung collapse. Then we have an HRCT chest, which was done on the 29th of June 21, in between both these X-rays, which was shown. We have the selected axial lung window images of the same patient. Here again, we see that there is a complete right lung collapse. In addition to that, we see that the right main bronchus is narrowed, and beyond this narrowing, we do not see the right main bronchus beyond this level. There are no areas of air bronchograms in this right lung collapse. The left lung appears normal. In the selected mediastinal window images, we in the axial sections, we see that in addition to the right lung collapse, and also again we see the right main bronchus narrowing, there are multiple fluid bronchograms in the right lung, suggesting that this is an obstructive collapse. These are the coronal reformats of the same CT. Here very well we can see that this is the trachea, and this is the right main bronchus, which is narrowed, and beyond this point we cannot see the right main bronchus, and we can see the fluid bronchograms again with features of volume loss on the right side. To summarize the findings in this patient, we saw that there was a subsegmental right lower lobe collapse, which over a month progressed to a complete collapse of the right lung with areas of fluid bronchograms in the right lung. There was a narrowing of the right main bronchus, and also we saw that there were multiple enlarged mediastinal nodes also in this patient. So this was a case of, to summarize, this was a case of bronchial stenosis with resultant right lung collapse, with the bronchial stenosis likely being due to tuberculosis.
Thank you, Dr. Malvika. So the case is a 26-year-old lady with history of TB 1.5 years back, symptomatic now since last 10 months, and now presented with a right lung collapse. So our impression is the right lung collapse due to right main bronchial stenosis. And the plan was to go for a diagnostic bronchoscopy. Before we go on to bronchoscopy, I would just briefly discuss the tracheobronchial anatomy. So this is the trachea that divides into the right and the left main bronchus. We focus on the right, which further subdivides into the right upper lobe and the right intermediate bronchus. The upper lobe has 3 subsegments, and the intermediate goes on to divide into the right middle lobe and lower lobe. These are the bronchoscopy images of the same. So on 14th of July, we went ahead with a diagnostic bronchoscopy. You can see we are going from the trachea carina to the right side. This is the right main bronchus. It is not just stenosed, it is completely obstructed. The whole opening is obliterated. We can see a smooth membrane was there. So now to decide what to do further, because we can't just dilate it. We have to decide how to go ahead to go beyond this obstruction. So seeing as it was a relatively acute collapse based on the recent radiology, we expected that the bronchus beyond may be patent beyond this obstruction. So we went with a GA procedure. Under iGel, we went ahead with electrosurgical knife incision. This is the electrosurgical knife through which we are gradually incising into that membrane with multiple applications of this knife carefully along the axis of the right main bronchus. We expect to go beyond this obstruction. So as we create this puncture in the membrane, we passed the guide wire. This guide wire was freely negotiated into the membrane, and this was done under fluoroscopic guidance. As it had passed freely, we expected it to be in the bronchial tree, and we advanced this balloon. This is a small sized balloon which we have advanced. The video may be clearer on the LED screen. So there is a radial expansion, and that led to the development of this patent lumen, through which we can see thick tenacious secretions coming out. This is the patent lumen, and then we go ahead with serial dilatation. Now this is a larger size balloon, a 6 millimeter balloon, which we have then again inflated with saline and expanded. A contact time of 45 seconds to 1 minute is usually given. and then deflated. This procedure is repeated multiple times and serial dilatation to the maximum size balloon that is possible is done. So when we deflated this, we found that there was a significant opening created. I would just like to show the fluoroscopy images. This is the guide wire that we had seen in the fluoroscopy. This guide wire, over it, then the balloon was advanced. This between the two dots is our balloon. So we can be reasonably certain that this has gone into the right main bronchus. Post procedure, there was some degree of aeration in the right upper lobe while the lower lobe remains collapsed. We repeated the same procedure about a week later. Post that procedure, after the dilatation, we had significant right upper lobe expansion. We went ahead with the check bronchoscopy after this procedure. As we can see, as we move on to the right main bronchus, we now have a patent right main bronchus. Although it is still stenosed, we could negotiate a thin bronchoscope, a 4 mm bronchoscope beyond the right main bronchus into the subsegments. These are the patent subsegmental levels of the right upper lobe. As we gradually come out, we can see that there are upper lobe apical and anterior segments also visualized. However, we could not visualize the right intermediate bronchus or the openings of the lower lobe or middle lobe. So we did get an expansion of the upper lobe. So in this case of post-inflammatory complete right lung collapse, our endobronchial intervention led to a successful expansion of the right upper lobe. Patient had significant symptomatic improvement. Our future plan is to go for serial check bronchoscopies every 6 to 8 weeks and repeat dilatation in case of pre-stenosis. I would now like to invite Dr. Rahul for the review of literature.
Thank you, Dr. Vidushi. Good afternoon, everyone. Today, I will be discussing the various features and management of endobronchial TB and associated airway obstruction. So, central airway obstruction is something which we encounter on an almost daily basis, and it can occur due to a myriad of causes. However, in our country, which still has almost 2 million cases a year, tuberculosis remains one of the most important causes of this. Tuberculous infection of tracheobronchial tree is known as endobronchial tuberculosis, and although the incidence has reduced after availability of effective anti-tuberculous therapy, the various studies have shown that still it persists from 6 to 54%. Trachea, primary bronchi, the upper lobar bronchi, and the right middle lobar bronchus are the most commonly involved sites. Various mechanisms have been proposed for development of endobronchial TB, which range from direct extension from a focus in the parenchyma, implantation of infected sputum into the bronchi through blood vessels and lymphatics, and also through erosion of lymph node into the bronchus. The various symptoms which are common in patients of endobronchial TB include cough, which may occur in up to 80% of the patients. Hemoptysis and chest pain are also common. If we get localized wheezing and decreased breath sounds in a patient of tuberculosis, that may be a clinical pointer towards involvement of the airways. These patients will also have systemic symptoms of TB like fever, anorexia, weight loss, and generalized weakness. Various studies have found out the risk factors for endobronchial tuberculosis. Female gender, symptom duration of more than 4 weeks, and no previous history of pulmonary tuberculosis have been commonly associated. Cavitary pulmonary tuberculosis, lung atelectasis, and young age of patients have also been found to be common risk factors in these patients. A chest X-ray is commonly done in all patients with respiratory complaints, but it is not very sensitive for diagnosis of endobronchial tuberculosis and may be normal in up to 20% of them. However, few findings which may indicate involvement of the bronchi are persistent segmental or lobar collapse, hyperinflation, or obstructive pneumonia. CT might provide an initial clue to the involvement of the airways in form of segmental bronchial narrowing, complete obstruction, or extrinsic obstruction. However, a definitive diagnosis requires bronchoscopy. Chung has classified the endobronchial TB as seen on bronchoscopy into various types, which include the non-specific bronchitis, where there is mild hyperemia and edema of the airways, the edematous hyperemic type, where there is significant edema and hyperemia of the airways. In actively caseating type, we see caseous material in the airways. Tumorous type, a tumor-like growth may be seen in endobronchial tuberculosis. In granular type, there will be rice grain-like nodules spread over the tracheobronchial tree. Ulcer might be seen, which is known as the ulcerative type. And all of these stages, if not treated early, will progress to the fibrostenotic type, which was seen in our patients. So the endobronchial narrowing may be classified based on the amount of the lumen involved. If it is less than 1/3, it will be grade 1. If 1/3 to 2/3, it will be grade 2, and more than 2/3, it will be grade 3. In our patient, we had a grade 3 luminal narrow. Persistent bronchostenosis might develop in patients despite adequate ATT. As in this study, the authors evaluated 145 patients who underwent bronchoscopy before starting of ATT and were found to have endobronchial tuberculosis. And even after completion of ATT, 30 patients still had a persistent grade 2 or 3 stenosis. The authors found that involvement of more than 20 mm of the segment at the initial bronchoscopy was a risk factor for persistent grade 2 or 3 bronchostenosis. Our patient had completed treatment, but yet developed persistent bronchostenosis. The treatment options available for endobronchial tuberculosis include antituberculous therapy, which has been proven effective. Local medications have been tried, like inhaled aminoglycosides and inhaled INH. However, there are no randomized trials for the same. Corticosteroids have been used. End-to-end anastomosis after resection of the involved segment would be ideal. However, that is not always possible due to patient-related or technical factors wherein the bronchoscopic interventions have a role. The role of steroids is slightly controversial, and it may benefit in preventing the stenosis due to anti-inflammatory action, especially if given early in the development of endobronchial tuberculosis. And in children, it has been proven to improve the endobronchial obstruction if it is associated with hilar adenopathy. However, it has not been proven in adults. The various bronchoscopic interventions which can be carried out include dilatation of the airways or bronchoplasty, followed by stenting, or ablative procedures like electrocautery, argon plasma coagulation, and laser therapy. Cryotherapy has also been used in these patients. So bronchoplasty or airway dilatation can be carried out using a rigid bronchoscope or a flexible bronchoscope. In rigid bronchoscope, the scope itself will act as a dilator, while in flexible bronchoscope, we pass a guide wire and a balloon over it and dilate the balloon, as we had done in our patient. So this is appropriate for annular cicatricial stenosis. However, one has to be careful because excessive inflation can lead to bronchial wall rupture. And it is less useful in active inflammation, calcification, and development of cartilage destruction. If multiple dilatation or ablative procedures are required, then a stent may be preferred. However, the stent-related complications like retained secretion, colonization of stent material, migration, stent fracture, and development of granulation tissue have to be kept in mind while going for stenting. This is a well-documented procedure and various studies are available. However, I'll just quickly go through a couple of them. So in this study, out of 35 patients who underwent 95 balloon dilatations, they retrospectively analyzed these patients and found that there was significant improvement in the lung functions immediately after procedure, and which was persistent even after 1 month. In a study from our center where we did therapeutics bronchoscopic intervention for non-malignant central airway obstruction, which included 7 post-TB patients, we found that there was significant improvement in dyspnea and cough scores from baseline to 48 hours post-procedure, which further improved at 4 weeks and 12 weeks. In patients who persist to have severe bronchiectasis, repeated pulmonary infection, or frequent hemoptysis, surgical option needs to be considered, which may be lobectomy or pneumonectomy based on the lobes involved. So we'll just like to conclude by saying that bronchoscopic intervention is a feasible option in patients with post-tuberculous fibrostenotic disease. However, if diagnosed early and treated aggressively, they can not, they might not reach that stage where they might require intervention. Thank you.
Okay, thank you, Dr. Rahul. So basically, as you can see, this was more of a therapeutic problem rather than a diagnostic problem. So it was the chronic sequelae of tuberculosis leading to complete whiteout lung, complete lung collapse in a young person, relatively acute. I won't say it was absolutely acute, but relatively acute onset, which kind of led us to do all these procedures. And ultimately, the aim is to open the airways to whatever best we can, so that at least the patient has a good quality of life. Otherwise, the lung is virtually gone. Well, before I open this up and ask my other colleagues, I'll also ask my department colleagues also who were there at the procedure for any comments, challenges. Karan, you want to say something about the procedure in general?
So this was kind of a situation which we see very commonly, but we intervene less frequently. This is a predominant problem we see in young female patients. Many of them end up with a complete bronchostenosis. More commonly, we see on the left side, and sometimes you just see a trachea smoothly ending into a right vein bronchus, and you don't even see an opening. So it's like an autopneumonectomy which has happened. Because it's long standing, we are sometimes we cannot intervene because we don't even know the site of puncture sometimes, and we can end into a blind tract into the mediastinum. In this case, because we had a time course in which it was relatively acute and an opening in which we had an idea maybe we could intervene, so we went ahead and tried to do this procedure. And the concern is that at least we can get an opening early, but there is a possibility of recurrent collapse happening because it's a small opening. We are never able to achieve a normal lumen of a bronchus. So I think the challenge is here in this patient also. The stents are challenging because stents itself led to a granulation reaction in the airways. So I think those are certain concerns. But this case was interesting because it was a bronchoscopic management of a complete stenosis rather than a partial stenosis. If you see the etiologies, tuberculosis is probably the second most common cause. The most common cause we would see is related to mechanical ventilation and artificial airways, in which we get a post-tracheostomy or a post-intubation tracheobronchial stenosis.
And so, inviting comments from audience. Yeah, the middle lobe and posterior lobe, actually, only the upper lobe as of now is patented. We were not really able to go into the middle and the lower, so it is a partial opening. We are still not sure about the status of the lower and the middle lobe. And probably one or two things, maybe I'll ask Ashu also to comment on that, whether any virtual CT scan or virtual bronchoscopy would have any role in this. Should it have been done? Can we do later to see the track the lower lobe airways?
So two, three things I want to bring out on it. One is, in TB, it's always a little tricky to decide when to intervene. It's sometime you're too early or too late, because even at the time of acute inflammation, you will see several times that there is an overt bronchitis. You can see a bronchial wall inflammation and narrowing, but it is too early to go in. So the debate can be that, can you really go in at the acute phase, and how soon is too soon and how late is too late? Because this is a patient who suddenly came to us, being treated elsewhere, but we have own patients on follow-up also who show during the acute stage, and despite adequate therapy then continue to go into a stenosis. So that is the point, that how is the earliest that you can treat after initiation of ATT. And second point, which Karan already brought out, that restenosis is a big issue and you really need to keep tracking restenosis. And although removable stents came about 15 years back, there was some noise in out of South Korea out of it, but I don't think it really picked up for this indication.
Just how often you find pleural effusion with endobronchial tuberculosis? I mean, this effusion and endobronchial tuberculosis, do they coexist or it's rare?
No, it is not rare. The only thing is, sir, normally we don't screen every TB patient for endobronchial involvement. That is so, endobronchial involvement is not something that we kind of look for in every patient. And so we cannot exactly say how much of endobronchial and pleural effusion will coexist. But yes, with a disseminated TB, pleural effusion is pretty much common. Like the one study which they showed the 145 patients, they did endoscopy, bronchoscopy in all patients of TB beforehand, documented endobronchial TB. Then they saw after ATT about 30% still had significant stenosis.
This case, how do we rule out active tuberculosis?
In this particular case, so basically it is a combination of radiology and symptoms, and if any sputum is coming out, we do the routine things to rule out the active TB. Yeah, Dr. Mohit wants to say.
Very nice presentation. But one thing I want to see, this Chong, Kong, all these most probably they are from Taiwan or Hong Kong or from the Singapore, the small countries. I think all these classification. The other day I was asking Dr. Dick Cruz, is director of Tata Memorial, why we talk of Sarnia classification, Samblin classification. Why not? This is we are the capital, TB capital of India, world. Why can't all this type of study will come from India? Why will all the time say somebody else's classification? And there are total, he might have seen total 2000 patients in your lifetime. What we see in a month, they see whole lifetime. Why we have not been, I mean, this is just a esoteric question, not related to this. And you will be happy to know that two of our work from All India Institute is now into the guideline of American Thyroid Association. It's done from All India Institute. Two recommendations based on our work from AIIMS in thyroid cancer. That's what I'm telling you. Why we should not be focused. As he treated 145 cases, bronchoscopy, followed them. Our major problem is we don't have any documentation. We see patient, we treat patient, we send them home. We never do from academic point of view. That's the reason why we, in this country we say we are the diabetic capital of the world, we are the tuberculosis capital of the world, we are young heart failures, all this. But we have never come out with something which is very long lasting, which is a classification related to all India issue. That's my point.
Agreed, sir. Absolutely agreed.
So there are two questions. One probably is directed to you and one for Ashu ma'am. Is there a way to identify the patients who can benefit from surgery early rather than repeat bronchoscopic interventions?
I think Dr. Ashu may, because if imaging helps in that.
It's actually very interesting, not just in context of bronchostenosis, on any stenosis, on any time that the lung is collapsed. You know, right from the time whether it's related to a lung parenchymal disease such as ARDS or it's related to an endobronchial obstruction, can you say that the lung is going to expand or not expand? So there is radiology techniques which are coming in. A lot of them are based on ultrasound and some are based on perfusion. Basically, you have to be able to judge the pliability of the lung. Yeah. So the pliability of a lung, say in context of pleural effusions, etc., has been studied a lot on ultrasound itself. It has also been studied in context of intubated patients. You see, patients who are on long-standing intubation, again, the question is, has it gone into fibrosis? Not gone into fibrosis. At which point what is done is that the CT is performed at 2 PEEP settings. And see, one is if there's a fluid, you can see lung expansion. You have to basically document whether the lung is pliable or not pliable. Or if the patient is intubated, you do it at 2 PEEP settings and you see how much the expansion is. But if none of those two situations are there, still there are soft signs if you do a good contrast enhanced CT to be able to say whether this lung is likely to expand or not.
Question like, as a surgeon, it always remains a dilemma like, how do I know that how long the stricture is? If there's complete stenosis and one is not able to negotiate the bronchoscope through it. So as a surgeon, I'll be interested in what is the length or the segment of the strictured segment, number one. And like, can we see the distant part of parenchyma beyond that stricture?
Okay.
So can we do something like a virtual bronchoscopy kind of thing in that situation?
Just a small, I mean, a brief comment too. We are running out of time, so I think it's something which I think we need to collaborate more on. There is no clear way for us to tell whether the distal segment is open or not when there is a complete bronchostenosis. Neither radiology can tell, neither a bronchoscopist can tell. So I think we might have to take an aggressive, not knowing what is going to come approach, in which we say try a bronchoscopic intervention. If say there is a problem on table or some issue, maybe we take a patient for a surgical exploration, or take up patients for surgical exploration when we don't know and see what comes out. So I think these are the things we need to work on because there are no clear answers.
The one, if it is a complete obstruction, that is the problem. If it is a partial, then of course one can put a guide wire, one can do fluoroscopy, all these things and try to find out. But in a complete, it's a problem. Doctor, Doctor.
I just wanted to know what's the long-term outcome of this procedure.
The long-term outcome here, see, if that depends upon how much the lung is going to expand. We should remember only the upper lobe. We have been successful only to open the upper lobe so far. We are not really expecting a near normal situation, definitely, but at least it will not be a auto pneumonectomy kind of a situation also. We may have to go in again to do serial balloon dilatations, or sequentially, and hope for the best. Actually, right now, the very long-term outcome we don't know. The lower lobe is still collapsed. Yes, sir. So it is bound to again stenose sometime or the other, most likely. We may have to keep on doing the procedure again. Thank you. Thank you so much.